Welcome everybody to tonight's COVID-19 update on new variants, treatments and emerging evidence. My name is Ben Dorr and I'm a member of the team here at the Medical Journal of Australia. I'd like to start by acknowledging the Gadigal people of the Eora Nation, the traditional custodians of this land, and pay my respect to elders both past and present. Well, tonight's webinar is supported by GlaxoSmithKlein plc, with educational content and speakers independently determined and selected by the Australian Medical Publishing Company. Let me now introduce our chair for the evening, Dr Jillann Farmer. Dr Farmer is a general practitioner in Queensland. She was previously Medical Director of the United Nations, based at the headquarters in New York for 8 years. During her tenure at the UN, she led the UN's internal response to the Ebola and the UN's New York response to the first wave of COVID-19 in the US, advising the Secretary General and the then President of the General Assembly. Dr Farmer also led work in partnership with the World Health Organization to develop decision support tools regarding COVID-19 and major event risk management. Since leaving the UN, she has worked as a Deputy Director General in Queensland Health and as a frontline clinician in primary care. Prior to serving the UN, she was a Medical Director of the Patient Safety Centre in Queensland Health and the inaugural Director of the Clinician Performance Support Service. So welcome, Jillann.
Thanks very much, Ben, and hi everybody. It's great to welcome you and wonderful to see such a great turnout tonight. We live in the most interesting of times. I remember exactly where I was when it became clear that COVID-19 was going to be a pandemic. And it's a moment that I'm sure most of you would remember as well and never forget. It's shaped the careers of our juniors who've had COVID-19 school or first couple of years of training. And I'm sure that in the coming years, we'll look back at this as the most interesting and difficult of times. We're living as history is being made, and in particular, the amazing rate of scientific progress to help us deal better and provide better care for our patients has been breathtaking to behold. So I'm really glad to welcome you all here tonight with a great panel that we have, a combination of a virologist, an infectious diseases physician and a respiratory physician. And with my salute to the researchers who've helped us move so fast, I'm really pleased to open tonight with Professor Andreas Suhrbier, who is an inflammation biology group leader at the Queensland Institute of Medical Research, Berghofer. He did his undergrad work at Oxford in the UK and his PhD at Southampton, and came across to Australia fairly early in his postdoc career. But he currently leads work in a PC3 COVID research laboratory and is working collaboratively with other players across the sector. His work is being used to test new interventions and also to help us understand better what might be happening with COVID-19 and in its impact on the different body systems. So Andreas, really pleased to hand over to you now and look forward to hearing from you.
Thank you very much, Jillann. Well, lovely to be here, and if Ben could throw me the first slide, number 3. The question, of course, that everybody's been asking for a very long time, where the hell did this virus come from? And we're now, it's very hard to get absolute certainty. This is science. We have probabilities, and the best guess we have right now is that this virus evolved in bats and made its way to humans, maybe via an intermediate host, very likely through the wet markets. And now it's infected millions and millions of human beings, of course. It's also spread from humans to animals, and perhaps also back from animals back into humans. So there are a lot of coronaviruses out there in many different species. And so the ability for this virus to spread, mutate, recombine, and re-enter different populations is really quite enormous. So slide 4, please, Ben. So case in point, of course, is Omicron, which is really leading the wave these days. And we don't really know where Omicron came from, really. It sort of came as a bit of a late player. And the origins of Omicron are still a bit lost. Some people think it was just hiding somewhere in a population which we didn't notice, or perhaps it went into an animal, changed, came back to humans. We really haven't got that much of an understanding of where this came from, but it certainly came out of the blue and certainly wasn't a linear evolution from the Delta variants. So slide 5, please, Ben. One of my favorite theories is that the virus actually entered mouse population and then came back to humans, changed and more virulent. Probably not true, but it's interesting. Nevertheless, the reason why this theory came up is a lot of the changes that Omicron has seen, and there's a lot of changes in Omicron. Were very similar to the changes we see in mouse-adapted viruses. But it illustrates, I suppose, the complexity here of this virome that's all across the world, across multiple species, with huge amounts of capacity to intermingle. We're kind of familiar with this with flu and birds bringing in new variants all the time, but this is perhaps at a much more significantly larger scale, given the huge number of humans infected. So next slide, number 6. So BA5 kind of dominated. This is the Omicron variant, BA5. We moved fairly quickly from BA1, 2, 3, 4 to BA5, and it's pretty much dominated Australia in the last few months, although it's probably already being rapidly replaced by BQ1 and BQ1.1 as we speak. The US data usually precedes the data we have here. So next slide, please. So this is a terribly large and complicated slide, and I only show this to illustrate how complex this whole area is becoming, that evolution isn't constant across all parts of the world. Each country has its own level of immunity, different temperatures, different ways of behaving, different human responses to the outbreak, different vaccination rates, different vaccines. And so each country is seeing some quite different strains emerging. And this rather interesting sim put up by Daniel Fauci, updates it every month or so, illustrates where things are moving in different parts of the world. And I've annotated a few comments from different people about how worrying each one of these developments may or may not be. So next slide, which is the antibody slide, number 8.
Andreas, we're just getting some comments from the audience that they can't hear well, so just increase your volume a little.
Okay,
just speak a little louder. That's great.
Okay,
Thank
sorry
you.
about that. Yeah, so the antibodies are the main drivers here by far. The immunity that you generate with antibodies neutralizes the virus, and the virus simply tries to change itself so that your antibodies are no longer effective. And this is driving all the changes in spike, which is what we're monitoring. That's what we saw in that previous slide, was all about changes in spike. But of course, the virus has lots of other proteins, not just spike, and a lot of those other proteins are doing stuff too. And one of the most important things that those proteins do in terms of viral pathogenicity is to corrupt the body's ability to fight viruses using the innate immune response or the interferon response. And next slide, number 9. And one thing that's certainly emerged is that although spike's been mutating pretty rapidly to escape those antibodies, there's also been a series of mutations in the non-structural proteins, the non-spike proteins, that has increased the ability of every new variant of concern to escape this antiviral interferon response. Of course, very important here because the virus enters the upper respiratory tract, replicates quickly, and spreads before antibodies are produced. So having small amounts of interferon produced quickly by, having interferon produced quickly by the nasal linings to prevent massive explosion of replication, very important to reduce the amount of virus that's secreted in aerosols and droplets. And if the virus can overcome that, it's able to secrete much higher levels of virus in each droplet. So if the next slide, number 10, There's another sort of important feature of virology that many people perhaps don't understand. When we talk about the sequence of a virus, we're really only talking about a consensus sequence. We can't cope with the massive complexity, we call it a swarm diversity, of viruses that exists in every human being. We just give you the consensus, the one that occurs most for each position in the nucleotide sequence. But this doesn't represent the complexity. In fact, recently a wonderful paper has worked out that every single patient creates, in the course of their infection, every single possible single nucleic acid mutation. And in fact, a very large proportion of the double mutation. So in some sort of bizarre sense, every patient is, again, a function experiment. That means the virus is constantly changing, hoping to hit a sequence that will give it a slight advantage for transmission, which of course is the big game for the virus. Move on to the next person. So what does that mean? Well, for the TGA, next slide, number 11, Therapeutic Goods Administration, of course, has got to work pretty hard because the vaccine manufacturers have got to come up with vaccines that work against the new variants of concern. And unfortunately, we've seen a couple of things that have gone a little bit wrong here. One is that they've decided to mix the new strain with the old strain. Not quite sure why they did that, because one of the problems is that you boost people with the old strain several times. So when you give them the bivalent vaccines, their immune response simply boosts what they saw before, rather than priming a good response to the new strain. So I'm not quite sure why they did that. It would have been better just to have a BA.5 vaccine and forget about the old strain, which, after all, has disappeared, essentially. But the TGA is, constantly trying to travel around the world and approve these vaccines. I met the guy last week at a conference. He's a busy man, trying to get all the information so these vaccines can be registered quickly as soon as they are seen to be safe and effective. So next slide, please. The other problem, which you'll hear from the clinicians later on, is of course the drugs that we have. And here are the antibodies, the monoclonal antibodies that we make that neutralize. This is basically a replacement for your own immune system. It's made in tissue culture and to very high titers, and you inject these antibodies, they neutralize the virus. Trouble is, of course, just like the virus is evading immunity in the population, by those changes, of course, will also render many of the viruses immune to these antibody products that we now have. And the poor old biotech companies, of course, have to constantly update their monoclonals, test them and see if they work. And by the time they're finished, there's a new variant. Very painful process, especially as these drugs cost a fair amount of money to develop. Now, the other issue, of course, is the combination antibodies, which we've seen with Evusheld. There's two of them. It's a good idea to have two antibodies, especially as we've seen, for instance, for BA.5 there, one of them is useless and the other one is still slightly effective. So having two helps a little bit, but you're now giving people a monoclonal antibody that doesn't really work. So next slide, please, number 13. Of course, the same applies to drugs, and we have a problem with, as these viruses change, these drugs are becoming slightly less effective, although many do still remain effective. A little bit of controversy, which we'll hear about later on, for the hammer drug there, and how well that's tracking in terms of the new variants. But as these viruses change, of course, we're going to have to monitor every single drug and antibodies for its potential effectiveness before we can use it. So, and now the last slide of mine, number 14, just to highlight one of the complexities that just about everybody in this game has, which is that what does drug effectiveness actually mean? And you hear this on the media at all. It doesn't work against this. It's not as effective as that. Well, what is effectiveness? It's preventing infection, preventing, hospitalization, preventing death, preventing long COVID. All of these things have to be separately evaluated. And the different immune responses, the antibodies and the T cells probably mediate to different things for those different the kinds of protection. Again, very complicated thing for people to sort out. It would be really helpful for me if the media could tell us when something's more effective. In what sphere, please? And because there are so many different ways of measuring effectiveness. So thank you very much.
Thanks very much, Andreas. And just for our participants, we are going to have time for questions at the end of the three speakers, but you feel free to post your questions now. If a question comes up while a speaker is speaking, you can enter that into the question field and I'll park it until we get to question time, but capture the thoughts while you have them. And thanks also to those who've been providing feedback on sound and on slide progression. We did get a message that the slides were not progressing, and we've tested that as best we can tell. It's an issue at the user end, but please do alert us if there are any other functional performance issues. We're working behind the scenes to try and optimise your experience. So thanks very much, Andreas. That's a bewildering array of challenges that this virus is throwing at us, and I'm very pleased now to introduce our second speaker, Dr. Adrian Tramontana. Adrian's a senior staff specialist in infectious diseases and general internal medicine at Western Health. And he, I think, was born and trained for our times because his interests include emerging and re-emerging diseases, tuberculosis, tropical medicine, HIV, and infections in immunocompromised hosts. And he has led a lot of work in particular around airborne transmission and the use of N95s. And for that, Adrian, I thank you and the colleagues who led that work every day to help keep us all safe at work. Most recently, his clinical work has involved management of immunocompromised patients with COVID-19 infection. So, Adrian, thank you so much for joining us this afternoon. It's great to have you here. Over to you.
Thank you, Jillann and Andreas. I'm now going to discuss the interaction between population immunity and emergence of variants, how that's affected the epidemiology of COVID-19. If we could move to the first slide, 16, please. Here we see on the left, compared to Delta, a marked reduction in effectiveness against symptomatic infection with Omicron to under 40%. By 3 months, essentially the vaccine, 2 doses of vaccine is ineffective at preventing symptomatic Omicron infection. And on the right, a 3rd dose of vaccine partially overcomes this loss of protection, but still somewhat disappointing level of protection of 60% against symptomatic infection. Next slide, please. This loss of effectiveness against of the vaccines against Omicron is also translated into loss of effectiveness against hospitalization. Recent data that's come out of the US in the Omicron period shows that these loss of effectiveness has continued with ongoing evolution of the virus. During the BA1, BA2 period, protection against hospitalization within the first 4 months was 79%, and this dropped to 60% during the BA4, BA5 period. But very sobering, the immune protection against hospitalization after 4 months following a 3rd dose was 41% for the BA1, BA2 period, reducing down to 29% of BA4, BA5 period. The 4th dose of vaccine re-established immune protection, but did not enhance effectiveness beyond the 3rd dose. Next slide, please. The epidemiology of hospitalisation in Australia, as shown in the orange graph on the top right-hand corner, demonstrates the major peaks in hospitalisation in Australia associated with the variants BA1 and BA4, BA5. Also of note is that the hospitalisations in January were likely attenuated by the uptake of the third dose of vaccine, as shown by the second peak in the graph at the bottom of the slide. Reflecting data on the shown on the previous slide of loss of protection after 4 months, there was a mini peak in hospitalisations in May, which is around 4 months after the peak in third dose vaccination in January. Boosted immunity is now predominantly derived from infection with minimal ongoing vaccination within Australia. Prior to the current wave, this immunity was waning due to the recent period of relatively low transmission. In the future, immune evasion of against circulating variants, as well as the what variants emerge and circulate, will determine the magnitude of future waves. Next slide, please. But as has pretty much already been mentioned, we clearly need vaccines with improved effectiveness against circulating variants. As shown here for the initial Moderna bivalent vaccine, the bivalent vaccine provides superior neutralizing antibodies against Omicron infection than the original vaccine. However, as shown on the right, it is worth noting that the monovalent vaccine produced higher antibody levels in those who had prior infection than the bivalent vaccine produced in those who had no prior infection. The far superior response of bivalent vaccine in those who had prior infection indicates the potential need of two-dose variant-specific antigenic challenge to achieve the desired variant-specific immunity. In time, we will see whether the wider array of neutralizing antibodies will lead to improved cross-protection to future variants. We will eagerly await real-world data from the upcoming Northern Hemisphere winter. I will now hand back to Jillann to introduce the next part of the webinar.
Great, thanks very much, Adrian. And we will be hearing from Adrian again shortly. But now it's my great pleasure to introduce Professor Peter Walk. Peter is a senior staff specialist in respiratory and sleep medicine at the John Hunter Hospital, and along with our ID colleagues, respiratory specialists have been deep in the front lines of this pandemic. Peter is a senior affiliate researcher at the Hunter Medical Research Institute and the Director of Immune Health Research Project at HMRI, with his interests being airway inflammation in the context of chronic airways disease. He's had an enormous amount of frontline experience in dealing with COVID-19, and I'm really pleased that he's been able to join us this evening. Thank you so much, Peter. Over to you.
Thank you very much, Jillann. And tonight I'm talking from the somewhat green but very soggy Tamworth, the traditional lands of the Gamilaroi people. Next slide, please. So I'm just going to introduce a case that we looked after earlier in the year. This is John. He's a 75-year-old retired teacher. He was diagnosed in March 2021 with a low tumour burden follicular non-Hodgkin's lymphoma. He had a background history of some maturity onset diabetes, not too badly controlled, no end organ disease. He had hypertension, chronic atrial fibrillation, for which he was taking, rivaroxaban, and that will become important a little later. And he had treatment for his follicular lymphoma, which was fairly standard, but included the B-cell depleting agent rituximab. and he had that in June 2021. Our rollout of the vaccine perhaps didn't proceed as quickly as any of us would have liked at the time. He got his first 2 doses of the AstraZeneca vaccine as soon as he could in August and September of 2021. And he then went on to have a Pfizer vaccine booster in January of 2022. He was seen on a routine appointment in January and had some, in May, and had some bloods done that you could see there. Everyone was happy with his progress, but as you could see, he was a bit lymphopenic, and he had quite a reduction in his immunoglobulins, particularly his IgA and IgG. Things changed. We moved on, certainly in New South Wales, and many of the restrictions and the public health measures changed quite dramatically. While John tried his best to avoid public places and places where he thought he might encounter infection, unfortunately, whilst minding his 7-year-old granddaughter, he acquired the infection in July of 2022. He wasn't terribly unwell to begin with, low-grade fever, sore throat, got a PCR test, was positive, was able to get an urgent telehealth appointment with his general practitioner, and they prescribed for him, quite appropriately given the agents and the medications he was on, molnupiravir. He started that and he completed the full dose. Next slide, please. Unfortunately, he continued to become unwell. He was admitted to hospital on July 22nd and really had a rebound in the severity of his symptoms. Fevers, chest x-ray showed bilateral pulmonary infiltrates. He was hypoxic. He had an elevated CRP. He required oxygen and initially also then went on to high flow humidified oxygen. We started awake proning him. His throat swab was repeated and it showed a fairly high theta estimate with a cycle estimate at 16. He received pretty standard treatment we were giving people for COVID at the time with IV remdesivir, dexamethasone and baricitinib. Unfortunately, he got worse. He became more distressed from his breathing point of view, more hypoxic, required CPAP and continued to prone, and fortunately stabilised over the next 6 days. We continued treatment. He gradually got better. He went back on to just low flow oxygen. And by the time we got to day 10, of course, we were due to stop all of his medication, particularly the dexamethasone, the remdesivir and the baricitinib. Unfortunately, as we stopped those medications, he started to become symptomatic again. On day 10, because of the isolation rules, he'd had a repeat PCR, and this was still positive, now with a threshold of 24. He's worsened in terms of his clinical state. His chest x-ray worsened, and he went back on oxygen with escalating requirements. We immediately restarted him on treatment again, and this, of course, is where we leave the nice firm evidence base that we have, and restarted him on IV remdesivir. We gave him dexamethasone again. We ended up, as he was still positive by day 20, with Evershield, somewhat out of desperation and clearly out of its registration approval. And he continued to be positive in terms of PCR, though did stabilise with treatment and gradually improved. By day 24, we decided to give him a 10-day course of Paxlovid. And by day 38, he was finally off oxygen and PCR negative. So I don't want us to really dwell on the last aspects of that because we really did what we thought we could possibly do without any evidence base. But here we have this, and could we have avoided the situation that John had found himself in? Well, as you've heard, he was vaccinated, but of course the effectiveness was questionable. He did his best to shield, but that's really a very hard thing for an individual to do as society changes and those rules changed and came down. Prevention of infection? Well, there's very little you can do if your family is infected, and particularly if they're not aware of their infection. And early treatment? Well, he initiated treatment, of course, with molnupiravir, and he didn't have Paxlovid because he was on rivaroxaban. We'll have a think about that, as some questions have now been raised about the efficacy of molnupiravir. Perhaps the biggest concern is, though, that at that time, when he received when he was infected and was infected with BA4, BA5, he probably should have received Evishield earlier in the year, and that perhaps would have prevented such a severe admission to hospital. So we know that people who are susceptible are at risk of hospitalisation and unfortunately death with COVID-19. UK data from over 30 million people that have been vaccinated with a third dose shows that older age group, particularly those aged greater than 80 years, are at a threefold greater risk of still having hospitalisation or death. Males are a little bit more likely than females. Comorbidities, 5 is a lot of comorbidities, but that's a 9.5-fold increased adjusted relative risk. If you're on an immunosuppressive agent, and John was on one of the most significant, that risk is 5.8-fold. And interestingly, chronic kidney disease, a 3.7-fold increased risk with an adjusted risk ratio. Next slide, please. So Evishield, Tixagevimab silagavimib, this is an antibody and the only antibody that is registered for pre-prophylaxis. It was isolated from the B cells from a person infected with COVID-19. It has an extended half-life so that it persists for a much longer period of time. And a single intramuscular dose has been found to cause a persistence of neutralizing antibodies at least up to 6 months after the dose. Next slide, please. So in Australia, it's been licensed since the beginning of the year for age greater than 18 with a poor response to vaccination, particularly immunosuppression. Any chronic disease and immunocompromised individuals age 60 and above. But it is a significant pre-prophylaxis. And when used in this setting, it has been shown to lead to a significant relative risk reduction for hospitalisation. And that relative risk reduction was about 76%. Next slide, please. So you can see that here in comparison to placebo, that single injection over the period of 180 days significantly reduced the risk of hospitalisation for those patients that received treatment. Next slide, please. When we look at the oral antiviral agents, as you've heard about, the first of these agents to publish was molnupiravir or Lagvrio, which has got pre-approval under the PBS. The initial trial was a randomized control trial of 1,433 individuals, adults aged greater than 18, all unvaccinated. They had to have at least one risk factor of progressing on to more severe disease, and they had to be treated within 5 days of infection. The variants that were almost certainly circulating around at that time were the Alpha and the Delta strains. So in this patient population, treatment with molnupiravir did reduce the risk of hospitalisation or death at day 28, an approximate relative risk reduction of 48%, which means you need to treat 15 patients to prevent one hospitalisation. It's contraindicated in pregnancy and with breastfeeding, and in fact, contraception is recommended for up to 3 months after its use. Next slide, please. The second agent that we've had available is Paxlovid, or nirmatrelvir ritonavir, and a very similar trial population, 2,246 adults aged 18 and above, unvaccinated again, at least one comorbid risk factor that they may go on and develop more severe disease, and they had to be treated within 5 days. This was perhaps a little more effective in the initial trials, a relative risk reduction of 89.1%, though the number needed to treat was roughly the same at 16. But you can see here significant reductions in hospitalisation and no deaths in the group that received Paxlovid. Next slide, please. Of all the subgroups that they looked at, the older age group probably did better. So they probably got the most out of Paxlovid, and you can see that highlighted there in the age group greater than 65. Next slide, please. So the problem with nirmatrelvir ritonavir, though, is the ritonavir, which is there to boost the dose of the nirmatrelvir, which is the active component of the drug against SARS-CoV-2. Unfortunately, it has to be renally adjusted in terms of its dosing. But most importantly, ritonavir is a potent CYP3A inhibitor. And so there are some very important drug interactions. Down there are the websites you can go to look for those specifically. But next slide, please. There are some big do not use, and you can see those in red. And if you remember, John, the NOACs fall into that group. So rivaroxaban, apixaban really cannot use at the same time. In the context of chronic atrial fibrillation, perhaps that could have been stopped, though. Other agents, perhaps not so difficult. Simvastatin definitely could be stopped for the duration of treatment, and very few people, of course, on diazepam, midazolam, and I wouldn't worry about salmeterol necessarily. Next slide, please. There is now some real-world efficacy if we've moved away from alpha and delta, and we've started to see the use of these oral agents in populations that are vaccinated. This is a retrospective case control study from Hong Kong from February to May of this year, when the predominant strain present there was the Omicron variant BA2. They looked at both the efficacy of molnupiravir and Paxlovid and did seem to see an improvement in terms of both mortality and hospitalisation with both of those agents, though again Paxlovid seemed to be more effective. Probably about 60% of this patient population had had 3 doses of the vaccine. Next slide, please. However, that brings us to the prospective, though open label, UK platform trial, which is panoramic, which you've heard about earlier. So this was also a primary outcome at day 28 of hospitalisation or mortality, and patients were selected aged greater than 50 years with one risk factor to either receive molnupiravir or placebo. What they found was, in this group, in the majority of whom had received 3 vaccinations in the UK, that molnupiravir did not significantly reduce hospitalisation or death. There was a significant reduction in terms of time to recovery. The medication probably had an effect, but the overall efficacy was not that great. Perhaps that reflected the fact that variants had moved on. It almost certainly reflects the fact in a highly vaccinated population with significant disease, with a significant pre-exposure to disease, the efficacy of molnupiravir may just not be that great that we can see a real effect anymore. Next slide, please. In terms of effectiveness of Paxlovid in reducing severe COVID-19 and mortality, we don't have any prospective randomized trial data, but this is again a retrospective case control study, so 4,737 individuals from Israel, 2% treated with Paxlovid, 75% vaccination, and you can see here still a significant protective effect from Paxlovid in this patient population. It, however, appeared to be most effective in those people who are at most at risk, particularly older patients and individuals who are immunosuppressed. So next slide, please. And only really a word of caution at the moment. While we're fairly selective about nirmatrelvir, ritonavir, and our oral antiviral agents, we do need to be aware of the fact that with the use of any oral antiviral agent, we do have run the risk of inducing both a resistance in the actual virus and driving it towards more resistant variants. Now, we haven't seen a widespread problem from this at the moment, but this is just one evidence here from a clinical research trial that has looked that you can see variants growing in vitro, so not in individuals, but you can see mutations that have been acquired by the virus that have a high clinical burden that will prevent the effectiveness of Paxlovid. So widespread, indiscriminate use of Paxlovid could well be a problem under these sorts of contexts. So thank you very much.
Thank you so much, Peter. That's fantastically clinically pithy and something that I can really very much relate to. For those of us who've been working in primary care, I'm sure there's similar resonance. I'm now really pleased to hand back to Adrian, who's going to have some further discussion on variants and treatments. Thanks, Adrian.
Thank you, Jillann. I'm going to discuss some of the data Peter presented and extrapolate a bit on that. Can we move to the first slide, slide 38, please? I would like to start off by highlighting some missed opportunities for treatment of COVID-19 in Australia. As COVID-19 earlier this year was on track to be the third leading cause of death in Australia. The sad reality behind this is that there's been inadequate utilisation of some of our tools to manage COVID-19. One example, as shown by Peter, is Evershed not given as pre-exposure prophylaxis in those with moderate to severe immunosuppression who are unable to mount sufficient response to vaccination. The other missed opportunity is early antiviral therapy is often not given to high-risk patients, despite being available on the PBS. Next slide, please. I put this slide up and it demonstrates a number of things related to the case that Peter actually presented. The natural history has, in the immunocompetent patient, 7 to 10 days of viral replication and then a transition phase that eventually results in a inflammation phase of immune dysregulation. And the treatments we use are really directed at the different phases. As Peter showed, the immunocompromised do not follow this natural history pattern. And one of the real gaps in evidence is that the immune modulating therapy during viral replication in immunocompromised patients may actually further impair the clearance of virus, which is actually what is required to lead to resolution of infection in these patients. Next slide, please. As already mentioned, in immunocompromised patients, there's often prolonged viral replication, and this often persists despite antiviral therapy. Emergence of on-treatment antiviral resistance has been documented as shown in the diagram on the right. And the evidence for treatment for this group of patients is basically very little. We try to extrapolate it from the general population. But really, this group of patients require multidisciplinary care with experts. One is for the antiviral component, but two is also the management of immunosuppression during the COVID infection. In my practice, we were seeing such poor outcomes with single-agent therapy that we now use dual-agent therapy in this group, as was the case Peter presented. Next slide, please. Data from the panoramic study that Peter showed demonstrates that the hospitalisation risk has changed. The hospitalisation in that study was only 0.8%. And hence, you're not going to prevent hospitalisation if you're trialling the drug in a group which don't need hospitalisation from COVID-19. And now there's emerging data on the change in risk factors for hospitalisation in vaccine breakthrough infections. And US data overlaps with some of the data that Peter presented, age, immunocompromised, but the comorbidities of note is chronic end organ damage of heart, lung, kidney, and neurological disease. And this probably reflects reduced physiological reserve and inability to cope with the stress of infection. Time since vaccination was actually better demonstrated in the data I presented earlier. Next slide, please. What people may have also noticed from Peter's slides was the duration of illness. Not only was the duration of illness reduced from molnupiravir in the panoramic study, the Kaplan-Meier curves for time to recovery actually diverged out to day 28. And this really poses the question of whether these agents will actually prevent things like long COVID. In another preprint, observational data has shown that Paxlovid had a 26% reduction in long COVID. That is symptomatology and diseases post 28 days after COVID. Next slide, please. This study not only showed the reduction in a broad array of sequelae, but that these sequelae were not benign, and that Paxlovid actually decreased mortality and hospitalisation after 28 days after COVID-19 infection. Next slide, please. So I'd just like to leave with some key messages. One is around the need for up-to-date vaccines and vaccination. They still remain our essential tool for minimising the impact of COVID-19. And the bivalent vaccines, I think, will be valuable in this regard. Then, like Fluvax, they're not perfect, but extremely useful. We need to improve our systems for managing COVID-19 in the community, and particularly avoiding the missed opportunities for things like antiviral therapy and Evusheld for those who it's already been mentioned for. We need further research to determine our optimal antiviral prescribing, particularly target populations and target outcomes that we're trying to prevent. We need to look beyond death and hospitalisation and look at complications like long COVID, as shown in the previous study, of preventing things like PE, cardiovascular disease post 28 days. And management of immunocompromised patients really needs a solid evidence base. Currently, it's evidence-free zone. I will, next slide, I'll hand back to Jillann for questions.
Great. Thank you very much, Adrian. So some questions have been coming in, and I've been doing my best to triage them while the speakers have been progressing. If you would like to request a particular speaker answer your question, please indicate that in your question. Otherwise, I will throw the question to a panel member that I feel sort of most suited for it. So, Adrian, you were talking about the bivalent vaccines, and Andreas, I'll come to you on this one as well. I'll get both of you to give an opinion. The question is, of the bivalent vaccines, what should we be recommending to patients for boosters? Understanding that any booster is probably better than none, but some patients are difficult to convince. So what should we be advising patients at the moment, Adrian?
I think the bivalent vaccines are going to be very useful because they stimulate a broader array of antibody responses. And as we saw with the Moderna study, the neutralizing antibodies are so much higher against Omicron that they're going to provide better protection. Obviously, we need real-world data on this. And the other factor that we really don't know is the exact timing of this. So obviously, the best time to give it is before the next major wave. However, we can't really predict that. So I think this depends on the patient population that you're looking at. If it's an elderly or vulnerable person, I think giving the bivalent vaccines now is a good idea, because most of those will be at least 4 months, but probably even 6 months post their last dose of vaccine. Whereas if it's a younger cohort, it may be best pre-winter, and I think that's what ATAGI is probably leaning towards.
Thanks very much. Andreas, do you have anything additional you'd like to add?
Yeah, I suppose I just want to easily to say the obvious. If we continue on the Omicron migration, the obvious thing is to find a vaccine that you can find that has the latest Omicron in it. The BA1 is becoming less important, so the one that contains BA45 is probably more viable. And as we move to BQ and other vaccines become available, I would be following those vaccines, because these changes that you see as this evolution progresses can substantially reduce the effectiveness of these vaccines. So get the one which has the most recent variant in it.
Thanks, Andreas. Really. The next question I'll channel over to Peter and Adrian. I may then do what I've just done with Andreas, ask you for any additional comment. This is a question about patients who are not originally eligible for antivirals, so people who are ostensibly young and fit, but somehow end up hospitalised, requiring admission with severe disease, but weren't eligible for antivirals. Is there any evidence to support the use of antiviral in subsequent COVID infections in that cohort? Peter?
Well, look, it's a good question. But no, I'm not aware of any specific evidence that would support that. So I guess the person's asking, they're otherwise fit and well, they had COVID and got very unwell with it, and now they have a second infection. I could certainly understand the desire to prescribe it, and perhaps I could talk myself into being convinced they had significant immunosuppression as a consequence of their first COVID disease, and had my hand on my heart when I wrote the script and said that that was the case.
A wonderfully pragmatic answer. Adrian?
Well, overall, it's an evidence-free zone. Obviously, they're going to, following their COVID infection, they're going to have a boosting of their immunity, which will provide a degree of attenuation of further infections. So examining why they may have had severe infection would be important. I think temptation would say yes, but the evidence doesn't actually support it. And that's not that it won't, it's just that we don't have the evidence.
Thanks very much. The next question that I have is there any opinions on which vaccine is more effective, Moderna bivalent or Pfizer bivalent? Andreas, are you able to take that one? Which vaccine is more effective, Moderna bivalent or Pfizer bivalent?
I don't know. And I don't know if anybody knows. Most of these vaccines are now quite similar. These RNA vaccines are quite similar sort of design, and there's not a lot to squeeze between them. Better for what? As we said before, you have to work out what you're actually asking for. I would just repeat where I was before. The Moderna one has got BA4, BA5 in it. That's closer to what's circulating right now, and would, in my estimation, be worth considering. Of course, some of these vaccines are just not going to be able to be obtained by people, so just get any vaccine you can, in some sense, is also going to be the pragmatic answer. But really keeping up to date with the latest circulating variants is probably key to matching your best vaccine.
Thanks very much. I'm just scrolling through the questions here. There's a little bit of overlap, so I'm just sifting now. Would the panel comment, Peter, I might throw to you on this one. Can the panel please comment on the effectiveness of remdesivir for the treatment of the new variants?
My understanding, there's been a little bit of in vitro loss of efficacy, but that's probably not a great concern. There of course, hasn't been any clinical data coming out now for a little while with the current variants, but there is still quite a lot of widespread remdesivir use. Look, I think it's reasonable to take the in vitro data and say this agent still has a high level of antiviral activity, and so it should work just as well. I guess the only comment to make with that is that remdesivir probably works the sooner you get it as well. It's just an antiviral agent. The original trials gave it quite late in the course, or allowed it to be given quite late in the course, up to 10 days. But I mean, that was just a feature of the way the trials were designed and the way we were thinking about COVID at the time. Like any antiviral, you want to get something effective and you want to get it quickly and you want to get it before you get a lot of viral replication, because the real problem is the inflammatory response that happens as a consequence of the virus infection, as opposed to the virus specifically. So yes, remdesivir is still there and still probably pretty useful, I think, in our armamentarium.
Yeah,
Thanks
just
very
further
much.
to that.
Yep.
Sorry, just further to that. The initial evidence was early on. Remdesivir was used beyond 7 days of infection, which was basically not really helpful. But there was a Pine Tree study which showed a similar patient population to the Paxlovid and molnupiravir studies, and showed similar efficacy of almost 90% reduction in hospitalisation and death, given as 3 days intravenous therapy. And we use that sometimes in people like dialysis patients and transplant patients where we can't use Paxlovid. The downside is it's intravenous.
Thanks very much. Got a question here. What's the availability and cost of Evusheld? And I know we talked about this a little in our preparation sessions. Adrian, do you want to field that one? What's the availability and cost of Evusheld on and off the NHS?
I can't exactly recall the cost, but generally most of the cost of all these agents is relatively expensive.
Yeah.
I can't remember how many thousands. It is predominantly through the National Medication Stockpile, and it's been available through for those with moderate to severe immunosuppression. In Victoria, there's a list of indications and how to access it on the Department of Health website.
Thank you very much. I've got a question here as well on how seriously should we avoid or deal with the with caution group of drugs for use with Paxlovid? Peter, you touched on this. Would you like to field that one? How seriously should we take the with caution group?
Look, I think that's where you use your clinical judgment, and it depends upon the medication and the potential side effects that that medication may have. So that's quite tricky if you think about things like the NOACs, where excessive activity is going to lead to a significant bleeding risk, etc. And under those circumstances, perhaps you should just stop it and stop it for the period that you're receiving the Paxlovid. I mean, you have to weigh this up, and this is a clinical decision you've got to make with the patient in front of you. So if it's for chronic atrial fibrillation, what's their risk of having a stroke, etc. It's difficult. I made the comment about salmeterol. I really would not hesitate giving someone Paxlovid if I knew that they were on a salmeterol inhaler. I mean, that's neither here nor there. Sure, it might increase the activity, but the consequences of that are negligible, insignificant. So I think you've just got to weigh those things up, and look, where possible, just halt the drug for a few days. Cholesterol lowering agents, it's really not going to matter.
That's what they did with Joe Biden. He published that he stopped his statin for a few days while he took his Paxlovid. Yeah.
An interesting case of point, really. I mean, the presidents have trialled a few different medications, including his predecessor.
The White
but
House
of course,
is now a clinical trial site.
Yeah, and then of course the rebound effect is highlighted in him as well, and perhaps a 5-day course in some people is not enough. But this is again an evidence-free zone, and we need better evidence.
Thanks, Andreas. I'm going to channel the next question to you. What developments are there for vaccines that are effective for the different strains of COVID, i.e. the variant vaccines? We've touched on a couple of them. Are you aware of any others in the pipeline?
So we've got quite a few players in the RNA vaccine space. One would have to firstly say that this is probably one of the newest technologies to emerge in the vaccine space. And I've just come back from a huge conference on RNA vaccines in Melbourne, which was sponsored by Moderna. I think a lot of people are hoping this technology has a long way to go. And some of the talks really suggested that where we're currently at with these vaccines are that we're really just scratching the surface in terms of improving their efficacy. So a lot of hope there that we can make these vaccines a lot safer and a lot more effective. And an awful lot of new money is being thrown at trying to work out how to do that. Even the current vaccines we have are not just an RNA. There's an awful lot of clever technology that's gone into that to improve their release from these nanoparticles in which the RNA is encapsulated, get those nanoparticles to traffic to lymph nodes, get the lymph nodes to actually take them up into the dendritic cells rather than just flush out the other end, to get that RNA out of the nanoparticles into the cytoplasm, get them to the ribosome to translate into protein, etc. There's an awful lot of steps that make this thing work. And look, I don't have a feel for this, but it's about 1% efficacy was the kind of number that people were throwing around. So we've still got multiple orders of magnitude of improvement, we hope, ahead of us in this space. Keeping up with the variants, of course, is an absolute nightmare for these companies because they have to get this to clinic before the variant disappears completely in their vaccine is a waste of time. The cost of bringing a vaccine to market is still in the sort of $1.2 billion range US, perhaps slightly more these days. So these drug companies really have to spend quite a lot of money and hope like hell that when they're finished, they end up with a sales that can match the expenditure that they've done. So I think there is going to be an awful lot of development in this space, not just catch-up vaccines, but new technology being brought to bear to try and improve this. And I was astounded by the array of new technologies being used and tested. So I think we've got a long way to go there.
Thanks very much. Look, that takes us to the limit of our time. We've run a tiny bit over, and thanks so much to all of you who've stayed with us throughout the duration. I do apologise we couldn't get to more questions. One thing that I would just mention, you know, that the pace of change is astounding. I noted I got an email from the National COVID Clinical Evidence Task Force recently that they were on version 66 of their guidance, and it was just like, oh my God, how do I keep up with this? But we do, and you know, there's some great work happening in general practice with those very frontline things. My takeaways from tonight are: be constantly vigilant for those people who could qualify for Evusheld or its future equivalent. And be relatively trigger happy with those antivirals for qualifying patients, and watch the evidence space for emerging advice as we start encountering these new variants. Thank you so much to all of our presenters tonight. Just for the audience, I would like to just alert you to the fact that these guys had to rewrite their talks because the evidences have been evolving so fast. So what we've presented tonight is the very best we could do with up-to-the-minute information. And I'd like to thank the MJA for organising and hosting this tonight. Thanks very much, Ben, and back to you.
Okay, thanks, Jillann. I think that's a wrap.